So first of all, I would like to welcome everyone today to today's webinar on understanding your kidney biopsy. My name is Kristen Hood, Director of Clinical Outreach for NephCure Kidney International. And before I introduce our speaker, I'd like to let everyone know that we will offer a Q&A session at the end of this program. But throughout the program, please enter your questions in the Q&A at the bottom of your screen in that toolbar. So enter them at any time, all right? And we'll get to as many as we can at the end. This webinar is being recorded, and it will be as a living patient resource in our educational program section on our website. And I would also like to really thank our sponsors and recognize them for making programs like this come to you. And we want to make sure that the programs we do give you are relevant and things that you want to hear and know about. So I'd like to thank Travere Therapeutics, Goldfinch Bio, Pfizer, Mallinckrodt, Vertex, Boehringer Ingelheim, and Natera. So we have gotten quite a great support system here at NephCure, and Arkana Labs is another one that we just love having here today. So I'd like to introduce to you Dr. Chris Larsen. He is a renal pathologist and the executive director at Arkana Laboratories. He joined Arkana in 2009 after he attended medical school at the University of Arkansas, and he completed his pathology residency at Emory and then completed a pathology residency at Arkana. He has helped develop Arkana's molecular lab, directs some of the research activities there at Arkana, and serves as the executive director for Arkana. He's an avid researcher and has published many articles with his love of glomerular diseases, specifically in some areas of membranous glomerulopathy, APOL1 related kidney disease, as well as many other rare kidney diseases that we cover here at NephCure. In his free time, he likes to spend outside time with his wife and his kids. He is a member of the College of American Pathologists, the United States and Canadian Academy of Pathology, the Renal Pathology Society, and the American and International Society of Nephrology. Dr. Larsen, thanks for being here today.
Hey, thank you for having me. Yeah, it's a real privilege. Thanks, Kristen.
Yes. All right. Well, I'm going to turn it over to you.
Okay, great. Let me share my screen then, and we'll get started. Okay, so today, the main objective that we have today is to shed some light on what happens between a kidney biopsy procedure and when the patient receives the results. And so I'm targeting this. The target audience today is going to be patients. It's going to be patients who better want to understand their biopsy or their loved one's biopsy, and just to find out a little bit more information. In a sense, I put this black box on the screen. We really kind of want to open up this black box and shed some light on the methods of processing and interpreting a medical kidney biopsy. So we're talking here about, we refer to this as renal pathology or renal biopsies. And that is a very specific area of pathology. And that deals with biopsies that are performed for one of the indications that I've listed here on the screen. So this is when a patient has blood in their urine or protein in their urine or some sign that the kidneys are not functioning normally. And that is as opposed to a kidney biopsy that is performed for cancer. So when we say renal pathology or renal biopsies, we're not talking about tumors. We're not talking about carcinoma or cancer of any kind. These are biopsies that are intended to get to the diagnosis of why a patient's kidney is not functioning appropriately. So why do we perform these? Well, these are the main reasons. There's really no other way to definitively diagnose the cause of a patient's kidney dysfunction. Now, we can presume the diagnosis or the underlying cause of a patient's kidney disease based on their medical history, but sometimes it's just not clear based on the medical history what's actually causing the kidney disease. And in those situations, a renal biopsy will be performed. This is going to allow, and getting that definitive diagnosis is extremely important because it's going to allow the doctor to know how to treat that patient. And it's going to not only say how to treat them, but it's going to give them information on prognosis. You know, how likely is the patient to respond to any course of therapy? What is the likely course of disease going to be? And then lastly here, pathogenesis. That just means it allows us to understand the root cause. What's really driving this patient's kidney disease? So these are the reasons that we perform a renal biopsy. And as I said today, from this talk today, I want to show how we get from the procedure and, at the procedure, a core of tissue is obtained all the way over here to the report that, when you go back to the clinician and they tell the diagnosis, well, what happens in between? You saw the procedure, you see the report, and you understand kind of from the clinician what the diagnosis, but how did we get there? What happened in between? That's what we're going to focus on today. So I'll start with just a little bit of background. Kristen provided some about me. As she said, I work at Arkana Laboratories, and Arkana was founded, is a laboratory that was founded in 2001 by Dr. Patrick Walker. And Dr. Walker started this lab really with the intention of it being a center of excellence for renal biopsy interpretation. Today, 20 years later, we have 16 fellowship-trained renal pathologists, and we've expanded some into neuromuscular disease as well. So there are 2 neuropathologists on staff. But since it was formed, Arkana has really been well known for the level of service, just world-class diagnostic service that we routinely deliver same-day biopsy results for patients. Today, we read over 20,000 kidney biopsies in a year. And the way it works is that biopsy is performed. So today's Tuesday. Today, we received, roughly 100 biopsies that were performed on Monday. And by the end of today, we'll have a final diagnosis for each of those biopsies. And we'll call the clinician and have that discussion with the clinician so that they can move forward with treatment for the patient with minimal delay, 24 hours at most. So I could show a lot of pictures and describe kind of what happens in a laboratory, but we've got you here, and today it's just as easy, if not better, to actually take you into the laboratory. So I think you're going to gain a lot more understanding if we just show you what happens in the laboratory. So now I'm going to turn this over to my friend Denise, who's down the hall here at Arkana in the laboratory, and she's going to walk you through how a renal biopsy is processed in the laboratory.
All right, hi everyone, I'm Denise. I'm here at Arkana, and we just want to give you a quick look around our laboratory. And like Dr. Larsen mentioned, we want to show you how that kidney tissue becomes a slide, which becomes a diagnosis to your clinician so that you get the answers you need and as quickly as possible. So we start by sending kits out to our hospitals. These are kept in hospitals that use our service all across the country. And so here's what one of the kit boxes looks like. We send these out, like I said, ahead of time, and they keep them on hand there in the hospital. Inside is everything they need for sending your biopsy to us. We, first of all, like he mentioned, they take that tissue out of the back and then they'll put a piece in each bottle. So we have 2 bottles with 2 different liquids here, and a bottle in it with something called formalin and something called Michelle's. And we put a piece of tissue in each of these bottles, and then we will nest those down here in this foam inside of biohazard bags so nothing spills out. And then we also give them paperwork and instructions. Inside there is a piece of paper for clinical history, so we can get a better idea of what's going on with the patient, and obviously a FedEx pack that they can package all of this up in and drop it in a FedEx box. So like Dr. Larsen mentioned, everything that is done today will be overnighted to our lab here in Little Rock tomorrow morning. And so they will all come here, and then we begin the process with something called grossing and accessioning. And I'm going to bring in John. John here runs our grossing and accessioning area. So John, tell us a little bit about what happens when the packages get here this morning.
All right, so firstly, we receive the packages and we lay them all out on the counter. We organize them by East Coast versus everything else. We defer to the East Coast because since they're a few hours ahead of us here in Arkansas, they need to be called about a little bit earlier. We open up each of the packages. We verify the patient information is consistent and correct with the bottles. We separate each of them from each other using these little bins here, just something simple. And then we also put the transplants to the front because they require an extra set of stains that take a little bit longer. But other than that, we keep the East Coast going first, and then we send them through our system. We assign each patient a internal case number. And again, making sure everything matches up the entire time. Then we hand it off to our grocer, and we can have up to 10 grocers grossing at one time. The grocer takes the case back to both of the bottles back to one of the 10 grossing stations. They pull the tissue out, they measure it, they note those measurements on the paperwork, that our internal paperwork, and the color and any pertinent information that they may notice. The formalin tissue goes to light. We take small samples from the formalin tissue for electron microscopy as well. And then the Michelle's tissue goes to IF. And then that is, in a nutshell, the accessioning and grossing process.
Awesome. Thank you, John. Thank you so much. So yeah, the grossing, like he said, it can kind of be gross. Like they'll talk about all the areas, all the things that your tissue look like. If it's straight, if it's curled up, if it's bloody, if it's whatever. So they are really documenting every single thing that they see when they take that tissue out of the bottle, just again, for your safety and making sure that we know exactly what arrived here in our laboratory when we first opened the case that morning. So that's grossing and accessioning. And like John mentioned, from there, we take a piece of that tissue and we move it over to the first test that we do on the tissue. It's something called light microscopy. So we're going to run over here to the light microscopy area and see what happens there. We take that tissue, and then the first thing we do is it's a process called embedding. We have to get that tissue in a means that we can cut through it in order to get it onto a slide. So the first step is embedding, and this is Kaylee, and so she's a lead here in our light microscopy area. So Kaylee, tell us what this part looks like.
So what I'm doing is, I'm being careful to expose my tissue from the cassette, and I will transfer it over into my mold. And then I will place it at a 45-degree angle so that it ensures easy access, easy cutting for the tech. And then I will move it over to the cold plate, and I will apply pressure so that it is on an even plane for the tech to ensure cutting.
Awesome. So like Kaylee said, she's filling that. So paraffin wax is what we use to embed the tissue in. So we put it in this mold and we fill it with paraffin wax, and we have a cold plate over here on the side that lets that paraffin harden up. And it just sits in this cassette full of paraffin wax. And we put it actually in a little ice bath over here to keep it nice and cold and nice and firm to make the cutting easier. So after we get that paraffin firmed up, then we are ready to go over to the cutting area. This is Brandon. Brandon, do you mind showing us a quick slice through what cutting looks like?
Yeah. So we want our blocks ice cold, ready to roll. So these are what our kidney tissue looks like in the block. I'm going to mount it on our microtome. We're going to roll off some ribbons. A little bit of focus here. I'm facing off the block right now so that I can see the face of the tissue, and you might be able to see it slowly start to come in. So this is what we call a paraffin ribbon. And I'm just going to be very careful, and voila. And so we're looking for tissue without any wrinkles and folds, and we will then separate the tissue and mount it on the slide just like that. And we just go down the line and we put them on the slide in order that they're cut. And sometimes we get wrinkles in a few of them, so we'll skip over the bad ones. And we just go all the way down the line until we get all of the slides in our panel, which is anywhere from 13 to 15 slides, give or take. Just like that.
Perfect. Thank you so much, Brandon. Okay, so like you mentioned, he's putting that tissue on the slide, and we will do that for, like you said, 15 to 17, 18, sometimes more slides that we are going to put stains on. So they put the tissue in some racks, and they'll bring these racks over to these machines. These are staining machines, and they kind of do the work from there. They do the rest of it. So there are computers built into these machines, and a program of what chemical they're going to go in, what solution they're going to go in, and it just goes in and out of different things and gets stain put on it. And then it comes out with all kinds of pretty colors on it, and it highlights different areas of the tissue so that the pathologists can see certain things better than another. So yeah, that's pretty much it for light microscopy. Tissue gets embedded in paraffin wax, gets cut over on a microtome at very thin sections, so thin they have to put it on a water bath. Then they pick it up with slides. And once it's on the slides, they bring it over to the stainers, and the stainers put stains on them. And that's it for light microscopy testing. So from there, we do a test called immunofluorescence. So immunofluorescence is it's a different process. Same thing in terms of putting tissue on slides. But over here, we dump antibodies on them rather than stains that have a lot of color. We put antibodies on them, and we wait for this reaction. So if you're positive for, say, an antibody called IgG, then it will fluoresce. It will turn a really bright, pretty green if there's a positive reaction there. So let me introduce you to Beth and to Caitlin. They're going to help us out and tell us a little bit about immunofluorescence.
Okay, if you want to come around here, Caitlin here is cutting on what we call a cryostat, and she's cutting a case here. She's taken her bottom sections, and now she's working on her second row, her top sections, and she rolls off every section one at a time. And then she's putting cryomatrix on the slide. All right. And then after they get done cutting, when we get 6 jars, we then move over here to where we stain. And I've already got 2 cases set up here to stain. So what we're going to do is we apply each antibody. This is IgA, so we apply it on the IgA slide. So we just do a few drops per slide. And we stain all 9 slides with the case, and then they sit in these boxes like these over here that are covered for 30 minutes. And then when the 30 minutes is up, we put them over here on the aqueous cover slipper, and they cover slip, and then they dry, and then they go into these cardboard folders. And the reason why they go into these folders is because the IF slides are light sensitive, so this keeps them contained from the light so they don't lose positivity before they go over to the doctors. And everything that we do over here is hand stain. It's all 30 minutes. And the only thing that we put on the covers of the stainer is the H&E slides, which are here, and they go on one of the thermo stainers that Denise has already showed y'all over there.
Awesome. Thank you, Beth. Appreciate it. All right, so that's the magic for immunofluorescence. So tissue, a machine called a cryostat this time, and they put it on the slides, and then we'll make a different slide for every antibody that we're testing for. So routinely, we'll do 9 antibodies here, and then we can add on special antibodies depending on what kind of history the patient might present with. If we suspect any certain thing, we will go ahead and do some special antibodies for those as well. But antibodies on there, and this one is light sensitive, so we definitely keep it covered. Like she said, we'll wait on that magic fluorescence to happen. So, all right, so that's it for immunofluorescence. We're going to take a walk back here to the back of our lab where we do our electron microscopy. So I'm walking backwards, so if I trip, this is part of the game. So here in electron microscopy, this is one of the coolest areas of what happens to your renal biopsy tissue. We are dealing up there, we deal with small pieces of tissue that are embedded in something. Back here, it's embedded in electron microscopy, it's embedded in a resin, and it becomes a very small block. And we're dealing with pieces of tissue that are so tiny. Like imagine taking a grain of sand and slicing it into pieces. That's kind of what we're dealing with back here in electron microscopy. Very cool, very detailed. Takes a lot of time and training to get up to speed to know how to cut an electron microscopy block. So I've got my friend Brianna here, and she is working on a section right now. So the first thing that I will tell you is, again, how small it is. We cut on this bath right here, this blue thing. It's got water inside. It's called a water bath. So like the one we used up in light microscopy, this one is much smaller. And there is a blade on the edge. It's actually a diamond knife. And that's what we use to cut the tissue into these tiny pieces. So there's a little fleck on of black on the end of this resin block that's mounted right in here. And that is the tissue that we're working with. And Bree, why don't you show them, if you will, what a grid looks like? And tell them how you have to center that tissue in that grid.
So the grid has 100 spaces, and we place the glom in the center grid space of the grid. And of course, we have the machine with the eyepieces to do that. We're not doing that with our naked eye.
Because you can't see it with the naked eye, right? I
Right.
mean, it's so small. And so they're looking for something inside the kidney called a glomerulus. And that's the thing, like the glomerular disease is what we're diagnosing here. So they have to find that glomerulus that is intact and whole, and then they have to place it in the center of one of the squares on that grid. And like I said, that tiny copper grid has 100 squares inside, and so they have to get it right in the middle of one of those. And then that grid is what we'll put into our electron microscope, and that's what we'll scope and in order to examine the tissue at this level. So thank you, Brianna. Appreciate you. So from there, we go back to our electron microscopes. We take those grids that has the tissue in it, and then we bring it to an electron microscope. So up in light and IF and immunofluorescence, the pathologists are looking at slides on a microscope that's on their desks. So, and it's got a 10x magnification, a 20x magnification, maybe a 40x magnification. But back here, we're looking, this microscope is much bigger and way more advanced. And it's looking at things like 7,000 times magnification. So it is super detailed. So back here, I've got Jamie working on electron microscopy for one of our cases. And she is going to show us what this looks like. So over here is our actual electron microscope. So you can see what it looks like. It's definitely not something that sits on the pathologist's desk. Like when we go back to Dr. Larsen, you can see the microscope that he's got on his desk. This one is much bigger. And here's Jamie scoping one right now. Jamie, what magnification are you at?
So right now I'm at 800, but if we wanted to say, to help with doctors' diagnosis, we might zoom in and get a close up on these loops here. So we can go, this is at 15,000, the magnification of the original 10. And you can zoom in even further than that. And getting in up close can allow the doctors to make their proper diagnosis. And we keep in mind and look for abnormalities that can also aid in whatever it is that they are looking for.
So that at 15,000, I don't even know what that means. So 15,000 magnification, that's how zoomed in we are on that tiny piece of tissue that you saw us put in the middle of that grid. We've zoomed in and we're just looking at the basics of that.
So you can see here, this is the grid, one single grid spot that was originally on that grid that has 100 spots. And that glom sits within this one spot. So
And that circular thing, that's the glomerulus, right?
Yes, it is. So you have your glom structure here. And you have like your tubules, all of these things that you can find in the kidney that aid in filtration.
Awesome. Thank you so much, Jamie. I appreciate you letting us peek at you. So that's pretty much it. You'll notice the room was dark when we came in here. The electron microscopes like to be kept dark and cool, kind of the way I like to sleep at night in a cold room that's full of black. So that is how the electron microscopes like to be kept. So again, they are highly specialized machines that can zoom in super tight to show the basics of that tiny piece of tissue so that the pathologist can make the diagnosis for you. So, all right, that's it. That's pretty much it for how a piece of tissue comes out of the patient and turns into a slide. We take pictures of those things that you just looked at in the EM, and the physicians will put those pictures as well as the slides that they cut for light and IF and marry all that up together and arrive at a diagnosis. So that's it. I am going to throw it back to you, Dr. Larsen.
All right. Thank you so much, Denise, and everybody over in the lab. That was a great tour. And these guys in the lab are highly specialized technicians, and we could not even begin to do our job without them. And I couldn't begin to do their job. So that we're really grateful for them. When they're done, when their job is complete, they turned out something like a tray of slides that a pathologist can take and begin to study so that he or she can render an interpretation. So I'm going to just show you, let me pull up my screen here. I'm just going to show you a little bit, start by light microscopy. And by the way, we talked about light microscopy, immunofluorescence microscopy, electron microscopy. All of these are routine parts of a kidney biopsy. So we usually do all of those in every kidney biopsy. So let me just start off by showing you a normal kidney. And then I'll just show you a couple of examples of disease states in a kidney. So this is a kidney biopsy as it looks on a PES stain on a light microscope. So this is the light microscopy. And what we're seeing here, these round structures are the glomeruli. This is a big focus in renal pathology, the glomerulus. It is the filtering unit of the kidney, and a lot of the disease states are classified based upon the findings in the glomeruli. Not all of them, but many of them are. So we do tend to pay extra attention to those. You'll see here a normal glomerulus. So around the glomerulus, I'll throw out a little bit of jargon. Some of you may be familiar with it, maybe not. We have a capsule, so that's known as Bowman's capsule. The glomerulus is held together by this pinkish red areas is called the mesangium. And then we have the glomerular basement membranes are these offshoots from the mesangium. So this is a normal glomerulus. Keep that in your mind. That's what a glomerulus is supposed to look like. We also see tubules. In fact, most of the glomerulus is not, most of the kidney is not made of glomeruli. Most of it is the tubular epithelium. And so here we see, you probably noticed that not all tubules look the same. There are many different segments to the tubules, and they're broadly classified into these proximal tubules and distal tubules. And we also closely examined the arteries in the kidney. So this is an artery. A normal artery does not show any scarring. It has a normal muscle layer around the outside. So this is what a kidney should look like. If we examine it on a trichrome stain, and we always stain these kidneys with multiple stains, we can assess for whether or not there is scarring in this kidney. I've already told you this is a normal kidney. So the tubules in this case are exactly like they're supposed to be. They're back to back to back. There's virtually no intervening space between the tubules. You see just a little bit of blue, but when a kidney begins to have chronic injury or long-standing injury, you begin to develop scar. So you develop fibrosis, and this blue would expand, and you would begin to see more of the blue than you do the red. This would be a kidney in a more scarred state. But this one that I'm showing now is normal. So let me show you a couple of the more common diagnoses a kidney pathologist, a renal pathologist would make. This is the most common cause. I'm showing you now the most common cause of kidney disease in the United States. This is what you see in diabetes. And you can tell that this glomerulus is very different from the last glomerulus I showed you. Maybe there's some areas here that look remotely just a little bit normal, but my goodness, what are these big solid areas of pink? They form what we refer to as nodules. This mesangial expansion, the expansion of the mesangial region, is the classic finding that you see in diabetic nephropathy. So this is a patient with diabetic nephropathy. Again, virtually all of the glomeruli look like this. If I were to show you the trichrome stain, you would see a tremendous amount of blue. See how the tubules are no longer back to back to back? This is a kidney that's now beginning to have some scarring. Here's a different patient. This patient's biopsy, the first glomerulus I landed on is abnormal. Let's see, I'll show you a normal glomerulus first. Here's a good field because we can see both. Here is a normal glomerulus at the bottom of the screen. Has normal Bowman's capsule. I'll let you just look at that for a minute, but look at the one at the top. This one's not normal. It's got a large solidified area. So this glomerulus has an area of segmental sclerosis. So there's one of the more common glomerular diseases that is diagnosed is known as focal segmental glomerulosclerosis. Well, this is the segmental glomerulosclerosis lesion. So this is the FSGS. This is the lesion that you will see in a patient with FSGS. Another patient here, I'm now going to show you a Jones silver stain. And so this silver stain, again, this glomerulus is clearly abnormal. You don't have to be a renal pathologist to know that. But what you're seeing in this glomerulus is that you're seeing a proliferation of cells in the glomerular space. And most of the proliferation is outside of the glomerular tuft. So this is known as a crescent. So this is a crescentic glomerulonephritis. Lots of different types of glomerulonephritis can lead to crescents. This is typically a very aggressive form of glomerulonephritis. And in this particular case, this is a patient who had a positive serology for ANCA, so one of the more common causes of crescents. So those are a few light microscopy. Let's jump back now over to the presentation. I want to show, because I have a few more. Let's see here. I think I lost my place in the presentation, but that's okay. Okay, so let me skip ahead to where we were. Then we also, in addition to the light microscopy, will also receive a tray of slides for immunofluorescence. This was that second area that Denise just showed you. And I'm showing you here a typical tray of immunofluorescence slides, and I've included here labels of the different stains that are routinely performed. These slides have a very specific purpose, they're interpreted entirely different from the light microscopy. The purpose of this test is to look for the presence of certain proteins, mostly inflammatory proteins that commonly cause kidney disease. So we do this by staining the slides with antibodies. Denise mentioned that. And these antibodies target the proteins. I've listed here IgA, IgG, IgM. These are immunoglobulins, heavy chains and immunoglobulin light chains. C3 and C1q are components of complement, as is C4d that's performed in transplant biopsies. And then fibrinogen and albumin. That's the routine panel. So I'm going to use a cartoon to try and just briefly explain what's happening when we perform immunofluorescence microscopy. So we're using these antibodies, and I've just drawn a little picture of one up here in the top left. And these antibodies have a fluorophore attached to them. That this fluorophore will re-emit light that we can observe on a microscope. So it's a signal for us to look for. And when we apply an antibody, these antibodies are intended to specifically bind to only certain proteins. So if that protein being tested for is present, when we wash the slide, if that protein's present, the antibody will remain on the slide. And not only the antibody remains, but that fluorophore remains. And that fluorophore is our signal. It emits this signal that lets us know that that protein we're testing for is present on the slide. So it gives us this ability to detect whether or not the protein of interest is there. Now let's look and see what happens if the protein that the antibody is targeting is not present. In this case, we would apply the antibody, and when we wash, all the antibody would be washed away. None of it binds. If none of it binds, not only do we not have the antibody, that fluorophore is gone, the signal's gone, and we will not see any staining, any signal when we interpret it on the microscope. So let me just show you what that looks like on a microscope. This is normal, black. This is interpreted in a dark field. So if you don't see anything, that means whatever you're staining for is not present. You see nothing. Here are some examples of positive. When they're positive, in this case, there's a specific fluorophore that emits a green color. So when it's positive, you can see that fluorophore. Again, bright green here, and you know what's being tested for. So you know this antibody was for, say, IgG. So from this, we can determine both the type of protein that's present, as well as the location of this inflammatory protein. So here's a glomerulus staining positive. Here you're seeing the tubular basement membrane stain positive. And over here on the right, a vessel that's staining positive. Now, I told you, we really focus on the glomeruli. So in the glomerulus, we go beyond just saying positive or negative. And when it's positive, we'll try to even specify a pattern. What's the pattern? So the types of proteins present combined with the pattern that we see in the deposits, it gives us really important information about the disease process that's present in that kidney. So now I'm going to shift from, we've talked about light microscopy. That's what I'm showing here. We've talked about immunofluorescence. Briefly, I want to cover what do we do with the electron microscopy. This is used because we often need to visualize glomeruli at a magnification higher than can be achieved by light microscopy alone. So for instance, in this picture, I'm showing a glomerulus captured at approximately 600, a magnification of about 600. That means it's 600 times what you could see with the naked eye. But with electron microscopy, rather than using visual light, we're using a beam of electrons for illumination. And this enables us to get information at a much, much higher magnification. So instead of 600, if we wanted to focus in on just this little area of the glomerulus, we could blow that area up to 6,000 times, instead of 600. And so when we get that high, again, I showed you Bowman's capsule. You're seeing just a portion of Bowman's capsule out here. You see the mesangium. Here's the mesangium on electron microscopy. Here are the glomerular basement membranes. So this is where blood flows here, and it filters the blood out into this space. This is Bowman's space. We can go even higher if we want to blow up this even a little more. We really want to see that glomerular basement membrane. We want to see it at a power of maybe 15,000 times. That's what I'm showing here. So here you can see the glomerular basement membrane. You can make out the inside. So here's a red blood cell. We're in the blood, the capillary space where the blood flows. Inside the basement membrane is lined by a very specialized cell type known as an endothelium. And this is a fenestrated endothelium. It has lots of small holes that you can make out here as kind of a dotted line. And on the outside of the glomerular basement membrane, you see what's known as the podocyte foot processes. This is normal. A kidney should have these foot processes lining up along the outside of the basement membrane. So we're looking at all, we can even get down to organelles this way. Here's the nucleus in this podocyte. So these are the kinds of things we're looking for. I'll show you a couple of examples here as well. Here we're looking at a red blood cell in the capillary space. This is a glomerular basement membrane. You see this in the endothelium here. Here's the podocytes, but look, these dense areas on the outside of the glomerular basement membrane, these are deposits. So this is the classic EM finding that you would see in a disease known as membranous glomerulopathy. Here's a completely different disease. We have a glomerular basement membrane here. Oops, let me go back. Here's the mesangium. And you see here that the foot processes, the foot processes along the outside of the basement membrane are completely eliminated. And we just see one continuous layer of cytoplasm along the outside. This is known as foot process effacement. And it would be what you would see in the electron microscopy from a patient with minimal change disease or a primary FSGS. And then here is an example of a glomerular basement membrane with the classic electron dense transformation that would be seen in a patient with dense deposit disease. So I've taken you through now kind of how we get from that biopsy tissue to a report. The renal pathologist is going to talk to the nephrologist. They're going to get the clinical history and they're going to put that together with the light microscopy, the immunofluorescence, the electron microscopy. Oftentimes even additional tests may be needed. If so, we'll order those. That may be some genetic testing, that may be some additional stains. So, and at the end of the day, a diagnosis will be issued that can then be shared with the patient and treatment can be initiated. So I really want to thank everybody for the attention today. And I want to put in one plug before I go. We love at Arkana to hear from patient advocates. So if that's something that you wouldn't mind doing, if you might consider sharing your story of kidney disease with the people who work here at Arkana, we would absolutely love to hear from you. This is the way that we who work kind of behind the scenes remember why we are doing what we're doing so that we can press on in this pursuit of excellence and in research and in diagnostic expertise. So if that's a possibility, I've included an email here where you can contact us, and you can also follow me or Arkana Labs on Twitter if that's of interest to you. So that's all from me, and we've got a little bit of time, so I'm happy if there are any questions to stay on for a little bit and answer those.
Thank you so much. That was so exciting, I have to say. On my end, I was just like, wow. Right into, I wanted to see even more. I think I want to be a renal pathologist now.
Oh, you should be. We'll take it. Come on, Kristen.
That is like a super cool job. We do have a couple of questions. We have about 15 minutes or so for some Q&A. So if anyone out there with some questions, please go ahead and put those in. So there's a question here. When do you think about using immunofluorescence after the kidney biopsy? Is that something that comes with the sample, or is it something that maybe you initiate on your end?
Absolutely, yes. So that is usually, most nephrologists are going to order the entire suite, all three of these modalities. There are additional tests that could be performed depending upon what we see on the light, the immunofluorescence, and the electron microscopy. But usually they will start off by ordering all three of those, because you really can't get to the final diagnosis unless you've done all of those.
Great, thank you. Another question, Veronica, she's asking, her son is 7 and he's had a biopsy, but she's wondering about the percentage. She speaks Spanish, I have to say. I've been chatting with her behind the scenes. She's curious how safe the biopsy is, and I'm curious if part of her question is how accurate the biopsy might be, if that makes sense.
Yes, that's a good question. There are risks with this procedure, as there are with almost any medical procedure. And so there are numbers out there in the literature. I don't want to quote any of them. In general, it is the majority of patients do not have any long-term complications or side effects, but definitely risks are something that you would want to consider before undergoing a kidney biopsy. As far as how accurate, when you perform a kidney biopsy, you are taking a very, very small piece of a much larger organ. So anytime that's the case, there is the potential for missampling, meaning that you don't sample the disease process. In general, that is, again, that's rare, but that's always a possibility. That's something that a renal pathologist is usually, should be trained to know though. So based on the clinical history, they'll know what the chances are that there could be a sampling issue. And oftentimes they might speak with the nephrologist about whether or not another biopsy, an additional biopsy should be performed.
Okay, great. Thank you. How do you determine on your end if the disease is caused by primary disease or secondary? Are you able to determine that?
Well, so there are several situations in which you could use that terminology, primary versus secondary. I'll speak to the one that it's most commonly used in, which is FSGS. Primary FSGS is when we say a renal pathologist says primary FSGS, what they mean is focal segmental glomerulosclerosis that is resulting from disease in the podocyte, also known as a podocytopathy. Those are those cells along the outside of the glomerular basement membrane. So how do you do that? We do that by looking at the kidney biopsy. In general, there are certain things we would look for on the light microscopy, but also especially on the electron microscopy, and also with the clinical history. In general, a patient with a primary FSGS is going to have what's known as a full nephrotic syndrome, which means they have a certain level of proteinuria, 3.5 grams per day. They have decreased albumin, and some of these. So it's a combination. It's a clinical and pathologic diagnosis combined, as are all renal biopsy diagnoses.
That's good to know. So Nyla has a question. Will you discuss cases? So I think one of the questions I had for you is, do you offer second opinions? Does Arkana offer second opinions? And if so, what does that process look like? And how would someone initiate that if they were looking for someone to read their biopsy slides and just maybe get another opinion? Yeah, sure. Yeah, so I mean, clearly we can't offer an opinion on something we haven't seen. So if we had if a second, consultation is routine in the pathology world. So if it's very common for doctors, patients, treating physicians to request a second consult or a second opinion on a biopsy. And so a patient can initiate that. They would essentially let their doctor know, or they would find the lab report and they would contact the laboratory where it was performed or read, and they would just let them know that where they would like it sent. And so you could say, we want the biopsy sent to Dr. So-and-so or to this laboratory or that laboratory. And when we receive that, we know exactly what that means, that if somebody's asking for a consult, they want us to look at the biopsy and essentially approach it from the start as though they've never, I try not to even look at the other pathologist's diagnosis, because we don't want to be biased by what somebody else has seen and diagnosed. We want to start fresh and we want to come to the diagnosis independently. Most of the time, I'll say the vast majority of the time, there will be agreement. I mean, the same diagnosis will be rendered, but it is true that sometimes does change the diagnosis. Yeah. Jill asked, does it matter which kidney is biopsied? No, in general, no. Most of these, particularly glomerular diseases, are going to be diffuse, meaning they're going to involve both kidneys. They're going to involve all parts of both kidneys. So in general, it does not matter. Okay. There are obviously, there's always an exception. I won't go through all the exceptions though. So yeah, let me ask you this. Does it matter who actually performs the biopsy? As far as your opinion as a renal pathologist, who do you prefer to actually do the biopsy? We want to see an adequate kidney biopsy. We want to, if a patient is going to undergo an invasive procedure, we want it to be able to yield diagnostic information. And so there are
good. And so in general, most of the time today, this has shifted over the last 10 years, 20 years. Today, interventional radiology will perform most of these biopsies. And then occasionally still some nephrologists perform them as well. You know, I don't have a preference as long as they do a good job. You know, if they give us good tissue to diagnose. You oftentimes will not be able to request who you want. Most nephrology practices have given up that procedure to interventional radiology. But, you know, if the nephrologist is still willing to do the procedure, I think that, yeah, you know, I don't really want to play favorites, you know, but I think that they do a really good job. You know, if it were an experienced nephrologist, bottom line, I want somebody experienced that has done this. They've done it multiple times. As with any medical procedure, it's always best to know that whoever is doing it has plenty of experience in doing that.
And like you mentioned earlier, if the sampling isn't, if you need something more, you would always relay that information. No one ever wants to probably go through another biopsy,
No.
but in order to get the best diagnosis, I could understand.
Occasionally it is necessary. Yeah, unfortunately.
Mm-hmm. How long does it take to read a typical biopsy? I know that it was in the tour, we started with the kit that arrives.
Yeah.
From that point to when it gets to your desk, about how long is that process again?
Yeah, so we've really condensed that period of time here at Arkana. So when I leave, when we log off of here, I'll walk over to the lab and there will be slides there waiting that are just coming off the stainers. So I'll kind of grab the first round, but through the afternoon, they'll be coming off. So, you know, from arrival until we have something to look at on the microscope, you're looking at about 5 hours. And then electron microscopy takes a little bit longer, but it will be ready by the afternoon. So as far as my job here, an individual kidney biopsy is something that, you know, we'll go through the history, we'll talk to the nephrologist. I've got several slides, as you can tell, to evaluate. So it's variable, but it could be anywhere from 1 to 2 hours for a patient's biopsy to be interpreted and resulted.
That's really cool. Let me ask you this. Sometimes what we hear from patients is that nephrologists don't go into a lot of detail from their biopsy results.
Mm-hmm.
And do you recommend a patient request a copy of their biopsy report? Or what if their nephrologist can't really explain the biopsy to them properly? Is there a way to connect with a renal pathologist? What would be your recommendation?
Yes, I mean, it doesn't, you know, patients don't frequently do this, but you can certainly, every diagnosis is signed by somebody. Today, that's an electronic signature, but there's a name on there and there's a phone number on there for the laboratory, and you can call and you can say, I would like to speak to Dr. So-and-so, Dr. Larsen, about my kidney biopsy. So, I mean, to give you some idea of how frequent it is, I would say maybe 1 out of 100 patients call me to discuss their biopsies, but some do, and I'm happy to do that. It is, you know, you can imagine, I couldn't practice nephrology. I'm not going to be able to manage a patient on dialysis, and likewise, a nephrologist is not really, they know how to interpret these somewhat, but they're not really trained like we are to interpret a kidney biopsy. So sometimes there is some advantage to talking directly to the renal pathologist.
So one more question in the Q&A, and then I have another one for you before we end today. But
Okay.
how can patients ensure their biopsy is read by a renal pathologist? So kind of on top of that, I'm kind of curious, how many renal pathologists are there? Are there some across the country?
Yeah, you know, it's a very small field. It's a real niche field. So I think if I would be guessing a little bit, I would estimate roughly 200 renal pathologists in the United States. It may be a few more, but there's not a lot. I would say I probably know most of them, you know, so, but you want to, on the front end, if you want to know that your biopsy is going to a renal pathologist, you could just ask the nephrologist. He's going to order he's going to order the biopsy, he should know where it's going to be sent. And so he'll be able to tell you whether or not that will be the case, where it's going to go. You can't always say specifically. Usually, I mean, some centers like ours have numerous renal pathologists, but if anybody here gets it, they're trained in renal pathology. So somebody sending here or to one of the other major institutions would be able to ensure, yes, absolutely, a fellowship trained renal pathologist is going to handle this biopsy.
That's cool. That's cool. So I know you mentioned it just briefly, but do you or your other fellow renal pathologists there, do you guys get to talk to the patients that you see their tiny cells of?
Yeah. Not enough. I mean, we
Not enough.
talk to them some, but not very much. Most of our we have a lot of conversations throughout the day with nephrologists. Every single biopsy we talk to a nephrologist, but oftentimes there's some back and forth, so maybe multiple times on cases. But we don't often get to talk to the patients, and we like to. So, and I like for everybody here, even, you know, I do rarely get to talk to patients. The people in the lab and that are doing research here almost never talk to patients. So, you know, that was my plug earlier. I love to facilitate conversations for them to hear from patients as well.
Yeah, that's awesome. So I will definitely add that into my follow-up email to everyone who registered today. So hopefully you'll get some feedback there. One last question. What's your favorite part about your job?
Problem solving. This is a job, you know, it's not just, you don't just look and have it. You really have to think. You have to put, it's like, I always compare it to working a puzzle. You know, you don't really know what you're looking at until you've put all the pieces together, and then you have to decide what's going on here. We talk with the clinician. I love to speak with the clinicians to discuss the patient and kind of what their plan is, kind of maybe even help them come up with a plan for their patient treatment wise. So that's what I like about it.
That's so cool. Thank you so much for today.
Yeah.
That lab tour was awesome. I want to come to Arkansas. I don't know if I've ever said that, but I think I would have just come to see you guys there.
Yeah, you should do that, Kristen. And anybody on this call, we welcome anybody. If you're ever in Little Rock, Arkansas, look up Arkana Laboratories. We love to have guests, and we'll take you through the lab in person. So thank you so much.
This was a great webinar, totally different than anything we've done before. And we really appreciate the interactive, you know, part of it with the tour. So again, everyone, thanks for being here. Remember, we have a precision medicine series going on this summer. So go to NephCure.org and check out our next event. And you can always find clinical trials near you, which is a key part of finding your precise diagnosis. To get the best treatment out there. And you can go to kidneyhealthgateway.com. Thanks so much, everyone. Thank you, Dr. Larsen.
Thank you. Yeah, thank you.